Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a traumatic cataract. The patient sustained injury with a nail, and the nail has pierced not only the cornea but also the anterior and posterior capsule of the lens, and the patient has developed this cataract. Cornea has been repaired about 2 weeks back. The eye is quiet, and I have taken up this case for surgery. The main incision has been made at 11 o'clock. This is a small side port. Now I'm going to stain the anterior capsule with trypan blue dye underneath this air bubble. As the dye injected, we can make out that only the upper part of the capsule is intact. The lower part is pierced, and the capsular material has retracted towards 5 o'clock. The visco is washed out nicely with BSS, and now 2% hydroxypropyl methyl cellulose is injected, and the anterior chamber is filled up with this viscoelastic substance. And now there is some adhesion, there are some tags between the wound and the cornea. I just cut that fibrous or some strands. Now I sweep a Sinski hook and find that it is free. So the iris is now free from the wound. Some more visco, the air bubble that is there is removed. And now I want to do capsulorhexis. I introduce a cystitome. Another small side port is made at 7 o'clock. Introduce the cystitome through this side port. A 26 gauge bent needle is introduced through this, and the anticapsule is incised. And now I take a utreta forceps, hold this capsular tag, and do a rhexis from the incision side to the right side, and it has been from say 11 o'clock to 7 o'clock. And this is just not capsule, this is some membrane has formed, and we cannot do rhexis like what we can do with capsule. We cannot do that. Now I tried to cut this capsule here, but I found a tag, another tag there, and I want to enlarge the rhexis superiorly with the help of this tag, and then I will use the venous scissor. So I hold this tag and do rhexis superiorly, and now it will be very much easy to use a venous scissor and cut the capsule superiorly. Yes, I have done that. Now I take the utreta again, hold this tag and do this rhexis. Now I don't want to pull this. I want to cut it with venous scissor. If I pull this, there may be some intact zonule inferiorly. In this case, my plan is to place a multipiece lens first in the sulcus. This is my first option. If I cannot do that, then I will think of scleral fixation of intraocular lens, or iris claw lens. The patient is a young fellow of 22. So my first option is to place a sensor or Technics multipiece intraocular lens in the sulcus. The patient could not afford a Technics multipiece lens, so a sensor multipiece lens has been selected in this case. And now as I try to aspirate the cortex, I can find that there is some lens matter dropping into the vitreous cavity from a gap and the 7 o'clock, just adjacent to 7 o'clock. And I can make out that the posterior capsule is torn. So the nail has gone from the right side, it has pierced the anterior capsule, it has pierced the lens matter and the posterior capsule. And now I have no option but to go for 3-port vitrectomy, because some soft lens matter will drop into the vitreous cavity. If I choose just to do pars plana anterior vitrectomy, a lot of lens matter will drop because this is a soft lens matter and the posterior capsule is already open. So my plan is to do 3-port vitrectomy in this case and remove all the lens matter. 3-port, one port is for irrigation into the vitreous cavity, another port for light pipe, that is endo-illumination, and the third one is for cutter. The cutting port and the illumination port can be exchanged whenever it is necessary, but the port for irrigation is fixed in the inferotemporal quadrant. I have closed the main one because as I try to put the trocar, there will be a lot of pressure and the eyeball may collapse. This is entry 3.5 millimeter from the limbus. Now I introduce the trocar, hold the conjunctiva. The conjunctiva, if we pull the conjunctiva will get torn. So we have to make that judgment that how much pulling, how much fixation we can do. The trocar has been introduced. This is for irrigation. This no vitreous came out, no fluid came out, so we can make the other trocars as well before injecting, before attaching the irrigating cannula to this trocar. Now this is another entry at around 10:45 o'clock, and one more entry is to be done at around 1:15 o'clock. These two superior ports is for introduction of cutter and endo-illumination probe. These are all 23 gauge trocars. Now the irrigating cannula is attached. And now I'm going to introduce the cutter, irrigation and cutter only at this moment. No endo-illumination, just doing anterior vitrectomy, because I want to remove the lens. You can call this is anterior vitrectomy as well as lensectomy is being done simultaneously. Very gradually the lens matter is coming out. Posterior capsule is also getting removed. My plan is to keep a good rim of anterior capsule and support anterior capsule which can support a sensor multi-piece intraocular lens. At this moment I am using IA, irrigation aspiration. As soon as I find that there is some vitreous strands coming to the port, I use cutter. Using cutter for some more time, and now here I am using IA, irrigation and aspiration. And now again the cutter. The machine being used is furrows. And now I go through the left side port and remove. My plan is to remove the cortex from the right side. At this time I am using cutter, removing all the vitreous from the anterior part. Now as I pull like this, I find that there is granular dehiscence at 8 o'clock. So I don't want to pull it further. I want to preserve whatever granular fibers are there. Sensor multi-piece lenses are very good in that even if few granule is intact, the lens can support itself in the sulcus. Now I am going through the limbus and I'm removing the cortex from the upper part. I am using only irrigation and aspiration with the cutter. And I find that it is coming nicely, which means there is no vitreous there. Yes, it has been done. Now I am using cutter for some time and then I come out. So it's a good idea to use the cutter and then come out, because if there is any vitreous strand that should not be pulled, it should be cut. Enlarging this side port little more. My plan is to go through this with the cutter. Yes, now this 23 gauge cutter will go easily through this side port. And now I'm going to remove this. Yes. Now I find that there is a piece which is behind this capsular tag, and if I pull it, there will be some more destruction of the granular fibers. So I want to go through pars plana and remove the chunk of lens matter through pars plana, and I can find that some more lens matter has dropped into the vitreous cavity and it is being removed nicely. Now I'm removing this chunk of lens matter through pars plana, and I am preserving the anterior capsular rim, part of the anterior capsule, which I want to use to support the sensor multi-piece intraocular lens. Now, vitrectomy is being done nicely. This is core vitrectomy, and along with this, whatever lens matter has dropped into the vitreous cavity is coming out. We can see that the optic nerve and macula is healthy. The retina up to mid periphery is okay. With this irrigating contact lens, we cannot see the periphery very well, but with scleral depression with a cotton taped Johnson part, we can see the periphery of the retina. So the chunk of lens matter which was there at 8 o'clock has come out, and now everything appears clean and not much work is left in the vitreous cavity. Now I have to come out and implant a lens in the sulcus. This core vitrectomy, I strongly believe that we have very competent phacosurgeons. They can learn this and they can do this. Fragmotome should not be used without complete vitrectomy, but cutter can be used to remove the soft lens matter like epinucleus, or even a very soft nucleus can be removed by cutter, by core vitrectomy, and this can solve 90% problem. Just a guess. Now I'm enlarging the main wound so that I can implant the lens easily in the sulcus. The initial wound was 2.8 millimeter. It has been enlarged to about 3.2 or 3.5 millimeter. Now I'm going to remove the tenor nylon thread, and now is the time to implant the intraocular lens. Before that, I want to separate, this dead adhesion between the capsule and the iris that formed is broken. And I find that there is a lot of lens capsule intact inferiorly to support the leading haptic of the intraocular lens. There is no genular dehiscence at 6 o'clock, but there is a genular dehiscence at 8 o'clock. So I can support the haptics at 6 o'clock and 12 o'clock. This is SPMC to protect the cornea. And now the lens is being introduced. This is a B cartridge of Alcon, but the lens is sensor multi-piece intraocular lens. The B cartridge keeps the left hand free, and we can support the leading haptic going behind the haptic. So the haptic is being delivered in front of this Sinskey hook, and now the lens is gently pushed in the sulcus. A great job indeed. And now this lens, the haptic, trailing haptic is placed in the sulcus superiorly. I don't want to dial the lens, because if I dial the lens, the drilling haptic will go to the area of jonular dehiscence, and that will be a very dangerous thing. Just want to support the lens here, just as this. Even if the lens is decentered little bit, the patient will get very good vision because the center of the cornea is not scarred and the macula is okay. The macula appears healthy. In the post-op period, we have to monitor the periphery of the intraocular lens. I see the periphery next day itself. Surgery is done today. Tomorrow morning, I will see the periphery of the retina without scleral depression as much as possible, and after 1 week with scleral depression. Now I am removing some visco from the anterior chamber, and some visco has gone behind. I want to remove that also. So I go with cutter and endoillumination, and I remove the visco from behind. I want to see the retina also and go a little more behind. And yes, there was a white dot of lens matter that also has come out at this time. Friends, the patients become very happy if there are no disturbing floaters. We should take care of this aspect. With modern machines with 5,000 cards per minute or 10,000 cards per minute, this core vitrectomy is very safe. We are not using fragmotum, which can be in the domain of trained vitreoretinal surgeons, but anterior segment surgeons can learn this core vitrectomy and address about 90% cases where there is only drop of soft lens matter, epinucleus or soft nuclear material. Now injected air, and this is pilocarpine. I want to constrict the pupil and see if the pupil constricts and becomes round or not. Yes, the pupil is constricting very nicely. This is a minimally edited video, and that's why the video is going to be long. But I want to share a lot of tips and tricks and ideas and thoughts in this video. That's why I didn't edit much. My idea is to encourage you, the very competent anterior segment surgeons, to learn this core vitrectomy. Now I just removed all the visco from anterior chamber. I flushed a gentle stream of PSS towards the cornea also to remove the visco that stuck to the cornea. And now I'm going to close the main wound with 10O nylon because the wound has been enlarged and I don't want to keep this enlarged wound without suture. So this is a 10O nylon suture. First, this is 2 throws. And then this is one more throw. And this is another throw. So this is a 2-on-on suture. The threads are trimmed and the knot is buried on the scleral side. Pull the knot towards the conjunctiva. See, if you go towards the corneal side, the wound gets gaped. The wound opens. So we should pull it towards the conjunctival side and bury the knot. And now the rest of the video is edited. As I removed the trochers, I found that there are some leakage, so I incised the conjunctiva, closed those sclerotomy openings with 10O nylon, and opposed the conjunctiva with releasable sutures. At this time, we can see that the pupil has constricted nicely with pilocarpine. I have injected some moxifloxacin, and this is a final lavage of the anterior chamber. The antechamber is being nicely formed, and I want to oppose the conjunctiva nicely. Before that, this is a bit of moxifloxacin. So this is the last step, injecting a bit of moxifloxacin. And now I oppose the conjunctiva to the limbus by these releasable sutures. 3 throws. 1, 2, and 3. 3 throws, hold the thread and pull it. And this is your releasable suture. Cut the thread with the needle short. Keep the other thread long. As you pull the long thread, it will come out. And this is done. We have some post-op pictures. These are 20 hours after surgery. Cornea is clear, antechamber is quiet, intraocular pressure is 14 mm mercury, unaided vision is 6/24. The patient is very happy. Thank you very much for your attention. Hope this video will help you in developing your surgical skills and inspire you to learn core vitrectomy.